welcome everybody to this brand new GISE Young format, Clinical and Statistical Corner. Today is our first episode, and this is a new format by GISE Young in which we would like to share our clinical cases and our statistical also knowledge as young operator, of course helped by experts. And it's very important for us that everybody could participate to these meetings, and this will be a very informal and interactive format. So I ask everybody at the end of the presentation to ask questions by chat and also by raising your hand. And everyone which is not GISE member is kindly asked to go to our website, gise.it, and to submit your inscription to GISE, to GISE Society, in the way that you can receive our newsletter, and which will provide you the link to participate to these meetings. The format is Friday morning, 7:30, 8 p.m. We will alternate clinical cases and statistical corner. And let's start. This is our first episode. Today we will talk about TAVI Challenges. Our operator is Antonio Soropago from Monza, and our expert is Dr. Francesco Saia, which every one of you know as our GISE president, and also TAVI expert and operator from Bologna. So the format will start with our presentation of the clinical case. So will share his case, and then Francesco will give you his opinion and just tips and tricks and for the case and also for the topic which we are going to talk about today. And then we will open the area for questions and interaction. So Antonio, please share your screen, and then we can start.
Thank you, Federica, for the introduction. And let me start by saying it is a real pleasure and also an honor for me to kick off the first episode of the Clinical and Statistical Corner, and to do it with such a beautiful panel. So as Federica, as you already mentioned, today we are talking about TAVI Challenges, and specifically a case of small aortic annulus with hostile vascular accesses. So let me dive right into the case. This is an 81-year-old woman. She's 155 centimeters tall and 48 kilos of weight. She has diabetes, COPD, and no prior cardiovascular history. She was admitted to the ER of our institution just a few months ago, and for pulmonary edema. After stabilization, as you can see on the right, her ECG was actually quite normal. So we performed echocardiography, which revealed that the patient had severe aortic valve stenosis with a high gradient of 41 millimeters of mercury, a tricuspid anatomy, preserved function of both left and right ventricles, and no other significant valvular disease. As we routinely do for such patients, even before heart team discussion, we performed an angio-CT scan, from which we gathered quite a lot of information. As you can see, the annulus, aortic annulus of this patient is extra small, a perimeter of only 59 millimeters with an area of 278 millimeters squared, a derived diameter of 18.8 millimeters. The sinuses of Valsalva are a bit larger than the annulus, but still not too big. So, of course, this is a small patient, but the annulus is actually, the aortic root is actually extra small. Coronary height are 13 millimeters for the left coronary system and 8.5 for the right. And the CT scan also shows that there is no significant coronary artery disease. Now it comes the real fun, as we found something unexpected on the vascular side of the CT scan. On the right side, you can appreciate an occluded superficial femoral artery. And on the left side, there are some tortuosities which are unfavorable for our eventual TAVI procedure, but also there are unsuitable calibers for transfemoral TAVI, specifically at the left, the ostium of the left iliac artery. So, moving on to the analysis of the right iliofemoral axis, besides an occluded superficial artery, we can appreciate that there are diffused there is a diffuse disease of the whole axis, with some points with reduced calibers and calcifications. At this point, I think we have enough material for a heart team discussion. Of course, this is an 81-year-old patient. She's frail. She has intermediate to high surgical risk. She's clearly not a surgical candidate. So we decided to plan a TAVI procedure. When we encounter extra small aortic annuli in TAVI patients, the first thing we do is to calculate the risk of patient prosthesis mismatch. As you can see, the predicted risk is actually low, both for a self-expandable supraannular device and also for an intra-annular balloon expandable valve. Of course, we know this is an extra small annulus, but it's also an extra small patient. So the predicted risk is not an issue in this case. We decided to use the smallest Navitor valve available and to take advantage of the FlexNav delivery system to try and do the procedure from the right iliofemoral axis. Of course, we prepared also a Plan B strategy, which I'm showing in this slide. We decided to plan the use of an expandable introducer sheath, specifically in this case an iSleeve from Boston Scientific. It is a quite hydrophilic introducer which performs very well in complex vascular scenarios. And as you can see from the table on the left side of the slide, the Navitor 23 delivery system is actually compatible with this introducer. So as we routinely do, we performed the procedure with an ancillary access from the left radial artery, and then we performed the angiographic control and angiography of the femoral access site before the procedure. So we have material to compare after the procedure. We actually confirmed that there is an occlusion of the superficial femoral artery, and we decided to perform an echo-guided puncture of the right common femoral artery and to pre-implant 2 troglodytes, as we always do. The procedure started with the crossing of the aortic valve and with the positioning of the Safari extra small wire in the left ventricle. The aortic valve was pre-dilated with 18 mm semi-compliant balloon while pacing on the LV wire. So we try and cross the femoral axis with the delivery system. And as you can see, the FlexNav does not get into the abdominal aorta, so it cannot overcome a calcific plaque of the ostium of the right iliac artery. At this point, we tried to position the iSleeve, which was able to reach the abdominal aorta, not without some minor difficulties. And then we were able to reach the ascending aorta and the aortic root with the delivery system of our selected TAVI device. As we always do, we start from a cusp overlap view to assess the depth of the implantation of our device. Then we move to a coplanar view, which you can see on the right side of the screen. We adjust for parallax, and we decide whether to reposition the device or to release it. In this case, we released the device, and this is the final result. Maybe the position of the TAVI valve is a bit lower than we anticipated, but there are no PV leak, there is no invasive gradient, and the coronary arteries are actually well perfused. So we are happy with this part of the procedure, and we move on to maybe the hardest part, the vascular access management. Before doing anything, we decided to position a pigtail catheter into the abdominal aorta, so to be able to perform angiographic checks to look for any signs of vascular damage while removing the introducer sheath. We positioned the dilator of the eye sleeve introducer onto the stiff wire, the safari, and then we started removing very slowly the introducer. After moving the introducer sheath into the right femoral axis, we checked for damage, especially at the point where we had the most difficulties advancing the introducer sheath and where the TAVI delivery system alone could not cross, which is the ostium of the right iliac artery. And as you can appreciate on the image on the right, there is no signs of damage of the abdominal aorta nor of the iliac artery. At this point, we completely removed the introducer. We administer protamine as we always do. We will close the proglide knots and we perform a selective angiographic check. It actually revealed bleeding at the puncture site. You can appreciate that it's actually a rather small bleeding. So how do we perform bleeding management? In this case, we decided, as we always do in such types of bleeding, first of all, manual compression for 5 to 10 minutes, but there was still bleeding. So we decided to perform balloon-assisted hemostasis. From the left radial artery, we decided to place a stiff wire, a supracore, into the profunda femoral artery, and to use a 540 millimeter balloon inflated into the common femoral artery for 3 minutes. This is the final angio. I'd like to remind you that we had already performed some manual compression. We are already after protamine, so there is no anticoagulation, and only 3 minutes of balloon inflation were able to definitely close the bleeding. This is the final result of the procedure the day after. The patient, as you can see, had a mean gradient of 6 millimeters of mercury. There were no significant PV leak at the echo, and the patient was fine. So this is how we managed this case. Now, I would like to ask Dr. Saya his thoughts on this case and what he would have done in such a case, what he would have done differently, and some comments.
Thank you very much, Antonio. This is a very interesting case. We saw a patient with at least 2 major issues. Number one is the annulus size, that, as you rightly pointed out, it's a small annulus, very small annulus. So you rightly considered the risk that in these cases, the patient could develop patient prosthesis mismatch. Second element of complexity is vascular access, because that was indeed a hostile access with some disease even distally to the puncture site, and especially the disease then of the axis, that interventional access that you had to use to implant the valve. Of course, in these cases, as you did, you should put everything into consideration and start planning your procedure. Okay, first considerations about the aortic annulus. Aortic annulus, in this case, I think you could use at least 3 different valves for sure. You could use the Navitor, as you showed. You could use Evolut 23 millimeters, and you could use a Sapien 20 millimeters. It's borderline, I think, for the accurate. It's a little bit big, but you may also try accurate valve in this case. So you have plenty of opportunities, but rightly you consider the risk of the prosthesis patient mismatch, and you decided for a valve that is intraannular. So in general, intraannular have a little bit higher risk of residual gradient, but on the other side, we know that this valve, the Navitor, has a very good hemodynamics, for example, in comparison to the 20 millimeter Sapien valve balloon expandable, which is also intraannular. And going for a valve like the Evolut in this case could a little bit compromise, for example, the coronary access, even if with small anatomies, coronary access is always complex. So it's something that you have to consider if the patient is not very old and has a baseline disease. But so you decided for the Navitor valve. Also, I think considering that this is a valve that is very well performing in terms of vessel navigation. And here we go to point 2, vascular access. Of course, in such cases, that you have already 2 different options. You can go for alternative access, or you can go for tackling the hostile vascular access. This is feasible, and when you do that, you have to keep in mind your strategy, and you have to keep in mind all bailout procedures in case you get into a complication. And you also have to think about a plan B in case your procedures is not successful. So I think you did all these things. You had a plan in your mind. I think you showed nicely that you can manage these procedures
that's
without the
funny
absolute
because they are
need
speaking
for,
in English, but we are all Italian.
Without putting a protection or contralateral wire, for example, because you rightly did it. You used as axillary access the radial artery. So in this case, again, you have to consider that you need to have in the room all material for bailout procedures, like you did in this case, because something that you need to consider when you have a secondary access radial is to have, for example, balloon with long shaft in order to get to the lesion, because if you don't have a shaft 135 or better 150, you may not be able to go down with the balloon like you did. Going back to the procedure, I think you managed very well. You showed that your plan A did not work in terms of crossing through the iliac artery, but you put the eye sleeve, which is a very nice sheath, expandable, that allowed you to go with the valve. And normally the expandable sheaths allows you to push very hard when you have difficulty in advancing the valve. The only thing that probably I would have done different from you is that when I see an hostile access, I prefer to prepare a little bit the vessel with a PTA, or better with intravascular lithotripsy, because this gives a little bit of elasticity to the vessel. Of course, with the PTA, whenever you have a stenosis or a very narrow site, you can enlarge the site, but also with the intravascular lithotripsy, you can modify, change the property, the elastic properties of the vessel, and this may help you. So this is overall my impression on the case, but I'd like also to take some questions or to discuss with you further about it.
Okay, thank you, Antonio. Thank you, Francesco. We have plenty of questions. So, from Claudio Guerriero, in part you have just answered, but I will read you all the questions. Very interesting, thank you and congrats. 3 questions. Out of curiosity, do you use routinely left radial artery as control access to facilitate going with the catheter to the lower body? Second question, role of low threshold for peripheral IVL to gain arterial wall compliance. Are you using it? And Francesco has already answered. What is your routine second access for TAVI, transcaval versus transaxillary versus carotid? And so, Antonio, if you want to say something, and then Francesco could answer also.
Of course. Thank you, Federica, and thank you for the nice question. First of all, we try to use the radial artery. It's the same to use the right or the left radial artery in all our TAVI procedure. Of course, when we have complex femoral accesses and we anticipate that there may be some difficulties as we do not perform the femoral access site protection routinely, and if we have a very tall patient, considering all the materials available at our cath lab, we sometimes still use the contralateral femoral artery as an ancillary access site. In this case, the patient was actually rather small, so we were confident that we could easily and safely use each of the radial arteries, and we decided to use the left one because it was the best one of the two, so we anticipated to have the least difficulties. As for the other questions, we perform as a alternative access, usually the axillary approach, but I have to say the rate of alternative accesses at my institution in this moment is actually rather low.
Okay, thank you, Antonio. Francesco?
Yeah, I basically agree. What is important, I mean, there is not only one right way to do things. You need to be confident with what you do. So in this case, it's not, nobody can say that it's wrong actually to go for an alternative access. Actually, we know from a multi-center trial that we performed that when you go with very hostile peripheral access, you have to take into account a little bit an increased risk also of stroke. But this is also true, for example, for subclavian access. It's not true for transcaval, but we know that, I mean, we are dealing with a very complex procedure. So it's something that you have to keep in balance. And again, there are different ways of doing things. Your expertise, your preference. In our center, as well as in Antonio's, we basically shifted to 100% transfemoral. And in terms of wire protection, as I said, again, nobody can say it's wrong. Actually, that's the standard way of doing. But more and more centers are doing now the procedures without. And when you put in place a clear strategy, like in this case, you can manage everything basically, because, you know, in terms of going from the radial, you saw that provided you put a pigtail or another catheter before removing the sheath, you have already access to the puncture site in case of issues, or to the iliofemoral access in case of any problems you should have. And also they did something that I'd like to highlight. I mean, they removed the sheath very slowly and checked while removing the sheath. Why this is important? This is important because in case you have a major issue, you can manage it directly from the femoral artery. You don't have to think of advancing a cover stent or something from the radial artery. So, I mean, having said that, I think this is of course, is absolutely correct to consider alternative access and based on your expertise and preferences.
Okay, thank you, Francesco, and thank you, Antonio. We have just a few questions. Evelina Toscano says, hello, everyone, very nice case. Any comments about the potential warning on CT scan that we should consider other than PPM in patients with very small annulus? And we just move to Antonio and then to Francesco as well.
Thank you, Evelina, for the question. I think that when we are dealing with small annuli, the chances are that the whole aortic root will be rather small. So this is the first thing that we can appreciate from the CT scan. So it's we know that when we are performing TAVI, we're not only dealing with the annular part of the valve, we're dealing with the whole aortic root. So we must always take into consideration the anatomy of the sinuses of Valsalva, the coronaries, the risk of coronary occlusion, the ST junction. It's a really multi-parametric analysis, I think, besides from the vascular access part that we already covered. What do you think, Francesco?
Yeah, absolutely. I think, as I mentioned previously, number one that you have to consider besides PPM is coronary risk, because in small annuli you may have increased coronary risk. Normally the anatomy is small overall. You have small sinuses of Valsalva, small STJ, so you need to take seriously into account the possibility, number one, to have a coronary compromise. Number two, not to be able to access coronary later. So if a patient has some coronary disease, if the patient is not very old, of course, you need seriously to consider this, the potential of coronary access. So maybe prefer a valve which is either small frame, sometimes a short frame, or which is clearly you can align with the coronary in order to preserve coronary access. Now we know that this is feasible with most of the prostheses. So this is a very good question. You have to take everything into consideration.
Okay, another question from Marco Toselli. When do you protect the access from radial access? We were just talking about stroke risk, and so this may be an issue also. Antonio?
We usually do not protect the femoral access site. I have to say we do it very, very rarely, and often when we decide to perform access site protection, we do it from the contralateral femoral artery. If we anticipate there is a high risk for vascular complication, we prefer to have another vascular, another femoral access, but it's mainly because of the available materials. So we prefer to do it from the contralateral femoral. We do not routinely perform protection from the radial artery. We, of course, have always a bailout strategy planned in mind if necessary, as in this case, but of course, it really depends on the patient. In this case, we could perform even balloon-assisted hemostasis because materials where we were able to use the balloon because the patient was actually not very tall, because we had a good radial artery. This is not always the case. So when we anticipate the real potential risk of, and we decide to protect the femoral access site, we usually do from the contralateral femoral.
Okay, what is your routine?
Yeah, I mean, my short answer is that you should do what you feel comfortable with. So I normally don't protect because I use the technique also that Antonio showed. So I put my catheter down before removing the sheath, and then you know, I can basically manage everything in this way. But you know, very expert centers and operator also prefer to always have protection wire. The protection wire can be easily advanced from the radial as well. Many operators cannulate the access, the iliac artery before the procedure, also to combine acupuncture with some angio. So I mean, it's not an issue. I mean, if you feel more comfortable having a wire, is not a problem. I don't use it, and I think that you can something can be avoided, but again, no hard feelings about that.
Okay, another question. The discussion is very interesting. Alessandro Beneduce asks, what are your technical tips for predictable navitor implant? My personal feeling with the device is that it is stable during the initial phase of the deployment, but the final position might be less predictable during the final release. Just flash answer, please, because we are just late. Antonio?
Flash answer is a very slow final release and maybe a little bit of pacing if we, especially if in the initial phase we find some instability.
Okay, Francesco, flash answer too, please.
Echo that.
Okay. Very last question from Attilio Leone. Do you have in your center covered stent with long shaft so that you can use them from radial access if needed? Maybe Antonio just answered for the protection, but maybe in case you don't expect vascular complication and you are from radial access, do you have a plan B strategy?
We do not have long shaft that we can use from the radial access. So again, we do things as I showed you. We go from the femoral. We perform multiple checks while removing the introducer, and then if we anticipate high risk, we move to the contralateral femoral.
Okay, Francesco. Maybe we can close this very interesting first meeting with your take-home messages. I thank you, Antonio, for his brilliant presentation, Francesco for having hosted as an expert, and everybody for the discussion and the question. Francesco, I give you the word.
Yeah, Antonio, can you put the slide?
Sure.
Take-home messages.
Right away.
Yep. Basically, everything has been said. We saw an very interesting case, as I mentioned, with a double complexity, two factors relevant to take into consideration. One was extra small aortic cannula. Those cases can be carried out safely, but you need to take into account the overall anatomy and especially the risk of patient prosthesis mismatch, carefully assess them. And also you need to think about coronary access. When you are in trouble for hostile access, expandable introducer sheets represents one of the possible tricks to perform a transfemoral TAVI in a complex vascular scenarios. They help you pushing very hard without increasing the risk of the procedure. But of course, there are alternative ways, like, for example, intravascular lithotripsy to prepare the vessel, or balloon PTA conventional. But most importantly, when you do such a complex procedure, you have to keep in mind very well your strategy plan, and have also a plan B and a bailout strategy in order to minimize the risk of complications and be prepared in case of complications should arise. So I think that this case showed well that you can take advantage of all available technologies that we have also in terms of transcatheter heart valves today. And so we think that we should tailor our procedure to each patient specific issue. And this case was a case in which the operator rightly balanced every issue and decided the strategy, the prosthesis, and tailored to the patient's need.
Okay, thank you again. Thank you, Francesco. Thank you, Antonio. Thanks everybody for the participation. I just remind you will find the registration of this first episode on GISE website, and then see you next time for next clinical case. Thank you again, and share our initiative on your social. Thank you very much. Bye bye.
Thank you.